This is the lecture on ethics, privacy, legal, regulatory, and financial issues in informatics. My name is Tom Payne. I'm the Medical Director for IT at University of Washington. The core content covered in this lecture can be found in the upper left-hand corner and lower right-hand corner of this slide. You can see the blue font. It represents a fairly small part of the total outline for clinical informatics, but a very important section, as I think you will agree, on reflection on the importance of finance and ethics in our field. If you zoom in on this outline, you can see a little more detail. There are two bullets in clinical informatics that have to do with ethics and professionalism, legal and regulatory issues, and then skipping ahead, we have sections on both capital and operating budgeting and principles of managerial accounting. Now, I don't know how many of you are familiar with managerial accounting. I have to admit that I wasn't when I started in this field, but by the end of this lecture you will know a lot more about it and hopefully be well prepared for questions in this area on the exam. Here's a listing of the key topics we'll cover, and they range from codes of practice and ethical codes on the global scale and then in the US and down to the local level. Then we'll switch to the principles of accounting and budgeting as they pertain to our field, managerial accounting, and then a review of some key concepts in financial planning that I think are useful to be comfortable with as you prepare for the exam. We'll start with the ethical and legal considerations, starting at the international level, moving into the United States in ethical codes, and then into United States law. The codes and principles we'll cover are at the international level: Article 12 of the Universal Declaration of Human Rights, the Hippocratic Oath, and the European Convention on Human Rights. And in the US, we'll talk about perhaps some codes that you aren't as familiar with: the Code of Fair Information Practice, the Belmont Report, Common Rule, and then the idea behind conflict of interest. If you visit the United Nations New York, you'll see posters of each of the articles of the Universal Declaration of Human Rights. These were prepared after World War II, and in those days, of course, often codes and laws referred to the male gender, and in that era information was stored in the written form, so you see reference to correspondence, but the principles aren't specific to one gender or to paper medium. And the basic idea is that maintaining privacy and protecting private information is regarded to be a fundamental human right. In the Western tradition, one of the earliest references to the importance of security and privacy of health information is in the Hippocratic Oath, which most of us took in one form or another. In this oath, you can see that we swear to keep what we hear in the lives of our patients in connection with our professional practice secret, concerning all such things to be private. So just as this still influences our practice in many ways, it actually includes a very, very basic mention of the importance of information privacy. This is the Code of Fair Information Practice that originated in the United States Department of Health, Education, and Welfare in 1973. This was much earlier in the history of technology and really did antedate the broad use of computers in healthcare, but you can see that the principles here influence what we use today to guide our use of information. I would say that these are elements of a code that we would regard to be aspirational, in that as you read them you may think of examples of where our society falls short, and yet I do think they ring true today. The points made here are that we do not have secret record-keeping systems, that if someone has information recorded in a recording system, it should be possible for them to find out what's in it and how it's used. Very interestingly, they make the point that if information is gathered for one purpose, we are not permitted to use it for other purposes without that person's consent. So you can see how this ripples through to current practice in informed consent and in Health Information Portability and Accountability Act. And the next element is also, it shows up in Hipaa, that there must be a way to amend a record. And finally, and this is important for our security discussion as well, that if you take on the creation of a collection of data, you also take on the obligation to take precautions to prevent misuses of those data. The Belmont Report and the Common Rule are very influential in managing information and in guiding our policies in our field. The Belmont Report, more formally it's referred to a report on ethical principles and guidelines for the protection of human subjects of research. It came from the late 90s, and its core was summarized in 3 bullets. First, respect for persons. Secondly, beneficence, the principle that we do no harm and we do the most good with minimal harm. And third, justice. This report found its way into federal policy, initially on a limited scale, but the policies that this report influenced were quite broad, and you can see that it influenced regulations in 15 different federal departments and agencies. And for this reason, this was referred to as the Common Rule, because it was in common to all these different agencies of the federal government. You can see, if you read it, that it heavily influenced what we use today for institutional review boards, for informed consent, and for our compliance rules. Yeah, these two, this report and this rule, look very familiar if you read them to what we see today, and they're very influential historically. Conflict of interest is very important in our field, in part because we are involved with systems and projects that are quite expensive. There's a fair amount of money changing hands, and we have influence over the decisions that lead to that expense. And so we need to reflect on our own ability to be influenced and what conflicts might arise from our own personal financial position. A conflict of interest policy is very common, both within our institutions and also in other areas if we engage in research or in contracts. I use here the example of the American Medical Informatics Association conflict of interest policy to illustrate several points that are common in these policies. First, conflict of interest pertains not only to real conflict but also to apparent conflict. If other people think you have a conflict, even if you don't, that can be a problem. The second point is that there's no monetary threshold for a conflict of interest, so you don't necessarily lose the conflict if the amount of money is low. Certainly the conflict may be regarded to be more important, but there is usually no financial threshold. It's conflict of interest usually refer to what to do if a conflict is recognized, and it can be handled or simply noted and addressed and made clear to all those involved. Switching to United States law, we'll discuss 4 examples of laws pertaining to ethical and legal issues in informatics. Sometimes we hold this course in Philadelphia, and if you visit Philadelphia, I recommend visiting Independence Hall, you'll see lots of publicity around the Constitution of the Bill of Rights. The Fourth Amendment to the Bill of Rights is very relevant to our field in that it discusses protection from unreasonable search and seizure. It mentions that people have right to be secure in their papers. Again, papers because this was the medium in which information was stored, and this right shall not be violated. This is really the legal foundation for many of our protections for privacy that we follow in clinical informatics. Fourth Amendment. The American Recovery and Reinvestment Act is critical to our field. It was led to a sort of a quantum advance in the use of health information technology in our field. You'll hear this mentioned frequently as ARRA. This act is divided into two divisions, Division A and Division B, and each of those divisions has multiple titles. These titles can be regarded as chapters in the full law. Two titles from Division A and one title from Division B together are referred to as the High-Tech Act. This is actually declared in the law itself. As you can see, I put an excerpt in there that what I just mentioned shows up in the law itself. So when we refer to the High-Tech Act, we're really referring to these sections of the American Recovery and Reinvestment Act. When discussing law regarding handling health information, we should remember that there are many ways in which information can be transmitted that are legal. A summary of this is shown in a figure taken from the Institute of Medicine publication called For the Record. This was published in 1997, and the entire book is available on the web free of charge. This figure shows a series of ovals, and the ovals have arrows connecting them. What it shows is that information travels from Alice's medical record to many places, including to her care provider, which one would expect, from the care provider perhaps to the laboratory, to a consulting provider. The organization paying for her care may be a managed care organization or a care delivery system, and that group has access to the information in carrying out their role. There may be review of Alice's record by accrediting agencies, by pharmacies if a prescription is written. If there's a wellness program, some of Alice's health record may be transmitted to that program. If there's litigation in some area of her care, attorneys in the malpractice case may have access, and by law many states require that some parts of her record be transmitted when certain conditions are noted or for collection of vital statistics. So the point of this diagram is that there are many different places that her private information legally flows. The question is whether each of these arrows is completely secure. And that is one of the challenges we face, that the need for information and its flow from one place to another incurs a risk. And that is why we spend as much time as we do on security measures. We'll cover security and privacy in greater detail in this lecture series, but it's useful to have a model and a context for these two concepts, and this is the outline of a model we'll use, which I think is quite helpful. It begins with threat assessment, an understanding of your assets in the form of a list of your assets, policy, education, and technical measures. So all of these are important, and if you overlook one of these elements, you may end up overlooking measures you need to take to protect security and privacy of the information entrusted to your care. There are several general rules of thumb or principles that govern privacy protections within the current generation of electronic medical records. First, it's very difficult to predict which clinician will need to view which record. Someone may collapse, someone may need advice from another physician or colleague, and it's hard to predict when this will occur. So as a result, most hospitals use a policy that governs appropriate access and then perform audits to protect against access to records for which physicians have no professional relationship. That's a rule of thumb that most institutions follow. Along with that are sanctions for inappropriate access. So this, in a way, could be viewed as a permissive policy, but with consequences for abuse if the policies are not followed. There are several overriding principles that pertain to the law and clinical computing systems. The first is the importance of authentication and authorization, and we'll come back to this. Authentication is understanding that you are who you say you are, and authorization is giving privileges based on your identity. The concept of non-repudiation means that if, for example, you have written a note in the record, that it's very difficult for you to convince a jury of 12 that you did not write it. So the concept is that you should not be able to repudiate what you have written if you followed practices within the EMR. Another principle is that patient billing is based on codes, and the codes are based on what appears in the medical record. And it's very important that it's in this sequence, that you don't bill before the record contains information that supports the codes that are sent to a payer. Audit trails are frequently used, and document version history is critical and called upon quite often. Audit trails show who has seen what, who did what, and when they did it. A document version history shows the forms of the document through its life cycle, from its draft to its final to its amended state, and so on. I believe if you've reached the point that you're sitting for an exam for subspecialty certification, that you already understand how important it is to have close cooperation with your institution's compliance and general counsel. Here's a quiz for you. True or false? The HITECH Act refers to sections of the Affordable Care Act that provide financial incentives for meaningful use of certified health records. And the answer is false. The HITECH Act is part of the American Recovery and Reinvestment Act, not the Affordable Care Act. So don't fall for that one. It is the two sections, actually three titles within the divisions of the ACCA that are referred to as the HITECH Act. CMS is very interested in how we use electronic medical records. And if you haven't looked at cms.gov, I encourage you to do so. You can find a version of what I'm showing you here on this slide, which is guidelines for teaching physicians, interns, and residents, and many other guidelines that CMS has posted. It's very interesting to note that the documents posted on this website include definitions of a macro and specifies how the macro can be used. It's used by active selection. This interest in documentation can really be tied to the fact that reimbursement is closely tied to documentation on whatever medium is used to create the documentation. So CMS posts their view of how these EMR tools should be used. If the documentation is to support a bill to CMS. As a reflection of the interest of CMS in electronic health records, I show you here a copy of a letter that came some 5 or so years ago from the Secretaries of Health and Human Services and the Attorney General at that time, Kathleen Sebelius and Eric Holder. So this is just is an example of how interested those two sections of the executive branch are in our use of EMRs. One of the sections of this letter that was mailed to American Hospital Association members, American Association of Academic Health Centers, American medical colleges, and many other organizations. It contains words that talk about how a record is created using copy and paste, and the concern that copy and paste be used appropriately. So all this by way of saying that the federal government is very interested in our use of EMRs appropriately, and the rules that they state for how reimbursement occurs and what documentation supports it are of great interest, and we are very wise to be aware of the details of those rules. And another quiz. This has to do with HIPAA security rule. Now, we haven't talked a lot about HIPAA yet, but note, first of all, that there's only one P in HIPAA, Health Information Portability and Accountability Act. So the HIPAA security rule, A, requires awareness and compliance of security professionals, but does not extend to the general workforce. B, requires protection against published and known security threats only. C, defines confidentiality, integrity, and availability. D, does not cover the availability of electronic PHI. And E, pertains to transmission and storage, but not impermissible use of ePHI. So the answer to this question is C, and I would refer you to hhs.gov for more information on the HIPAA security rule. It does recover availability of PHI. That's part of the definition of security. It does extend to the workforce. It does require protection against reasonable and future threats as well. And it pertains to ePHI in any form in which it is found. The Joint Commission has information management standards that are part of the Joint Commission review. Joint Commission was previously known as the Joint Commission on Accreditation of Healthcare Organizations. In the Information Management, or IM standards, there are 3 bullets under patient-specific information. Those include the requirement that the hospital has a complete and accurate medical record. Second is that there is information in that record on the care and treatment of services provided. And the last is that there's special emphasis on operative and other high-risk procedures, including moderate sedation anesthesia. So this is why many of the EHR vendors focus on operative and procedure notes and have provision to document high-risk anesthesia. It is something the Joint Commission looks for. You should be aware of another accreditation pathway. It's known as DNV. That stands for Det Norske Veritas, and it is growing in the United States market as an alternative to accreditation. In prior courses, some participants have pointed out that their hospital is using DNV instead of Joint Commission, but the principles are the same. Both would require that you have some policies to manage information regarding the care of patients in your system. Joint Commission also pays attention to your planning in the area of information management. There is a section that has to do with your methods for planning and designing for internal and external information needs. They also address confidentiality and security, as they should, and 3 sections address this area. So this is yet another reason for your organization to focus on the areas of privacy, confidentiality, and security. Continuing on Joint Commission Information Management Standards, there are sections that have to do with ambulatory care, including the requirement for a summary list for significant diagnoses, procedures, allergies, medications. And it's interesting to note that this preceded the meaningful use requirements and was somewhat more stringent, at least initially. 6.5 addresses the ability of certain personnel to transcribe verbal orders, and the last is the requirement that the relevant parts of a record are available when needed for patient care, treatment, and services. Your organization likely has a committee or work group that addresses medical records. It may be known as Medical Records Committee, or more commonly Health Information Management Committee. Usually the charge of this group is to oversee information management, to also oversee the implementation of a large number of regulations pertinent to medical information, to make sure that accreditation standards are met, review policies and procedures, and increasingly understanding how the record and the systems within the electronic health record impact information flow. There are advice and direction in areas listed here, and then there are audit and control functions for these committees to make sure that these steps are being achieved. Often this group is charged with preparing the organization for Joint Commission or other accreditation body review. The field of health information management is large and maybe overlapping with your role in your organization. The reason for this is that hospital leaders have an overall responsibility to manage information, and often this responsibility is delegated in part to the Health Information Management Group. Bylaws, hospital rules, and regulations often establish this committee and also establish professional staff responsibilities for information management. These policies guide a fairly large part of hospital or healthcare organization operations. There are a large number of regulatory bodies, both at the state and federal level, that have to do with health information management. Your state's Department of Health likely has regulations. The federal government certainly does, CMS, Medicare, Hipaa, and then, as I mentioned before, accreditation bodies are looking for your policies dealing with health information management in general and in very specific areas also. You might wonder what the Health Information Management Group works on each day. Perhaps you're involved with it, maybe you are not. Here are some key operations of the Health Information Management Group in organizations in many places. First of all, coding is a very important function. There needs to be knowledge of and utilization of clinical classification systems, of which there are many. Those specified by Hipaa include ICD-10, that's the International Classification of Diseases, 10, and you'll learn more about this in this course, and Current Procedural Technology, or CPT. The creation of a code is necessary for many reasons, including for billing and reimbursement for healthcare services, and also in research. These codes help to turn the information contained within records into a form that can be used for quality improvement and patient safety. a very important additional role for health information management operations is release of information. Here the acronym ROI does not stand for return on investment, but rather for release of information. This may seem like a straightforward task, but it is not. There are requirements to disclose health information to meet federal, state regulations. There are numerous requests daily for copies of records for litigation and for other purposes. That requires that we define what the record is and what the boundaries are, and then it has to be released in a timely way. The designation of the record to be released is changing, but has to be explicitly stated, and so that an attorney who asks for copies of a record is confident that all the record has been released and that nothing is potentially relevant is not available to them during legal proceedings. A very important operation is maintenance of the Master Patient Index and List of Encounters. The MPI is foundational to health information management and health information technology. If we don't know who the person is, then anything built on that record may be insufficient to deliver care, or even worse, it could lead to the wrong care being given if there's ambiguity. So we have to make sure that every patient has one medical record number and that every patient visit has some sort of identifier. And we usually refer to this as an encounter. It's not limited to a patient visit, of course. It could be another sort of encounter, but every episode is accounted for. Your colleagues in health information management have their own sets of credentials and certifications, and you may wonder what these are. First of all, there are coding certifications. Often there is a long series of abbreviations after a person's name if they're involved in coding, and these have to do with their certification to code in a particular domain, such as cardiology or some other very specialized area. There are privacy certifications, and there are general health information credentials, and these include RHIA, Registered Health Information Administrator, and RHIT, which is a Registered Health Information Technician. These roles are changing as our field changes, and the work of health information management is moving closer to that of those in clinical informatics. And now we will shift our focus to finance and to money. Very important topic in any field, particularly in health information technology and in clinical informatics. So we're going to talk about the key principles of capital and operating budgeting as they pertain to our field, key principles of managerial accounting, and financial concepts used in financial planning for clinical information systems. So this is hopefully review. I've given some references at the end if you'd like to go into more detail if this is entirely new to you. In general, this course is designed to review material that you already are familiar with, and so if you're not, it's well worth looking at some of these additional materials listed at the end. We'll start with some definitions. Capital and operating budgeting. Capital budgeting is a planning process for expenditure of relatively large sums of long-term assets. And in our field, capital budgeting usually applies to large projects such as implementing an ambulatory electronic health record or putting in a new radiology system. So these big projects happen periodically, but they aren't something that happens every day. So to plan for the successful completion of a large project, we develop a capital budget, which of course includes other items as well. Operating budgeting, on the other hand, is the detailed projection of all estimated income and expenses based on forecasted revenue during a given period, usually annually. And in our field, operating budgeting is the budget that governs the operations, day-to-day operations of our clinical computing infrastructure and our systems, keeping the help desk staffed, keeping the network maintained. All the things that are necessary are part of the operating budget. There are rules that determine what expense goes in which budget, and those rules may be set by your organization or they may be set by general accounting principles. So it's important to understand the distinction, and we'll cover this in more detail later. Continuing with definitions, depreciation. This is a key concept in our field. The formal definition is to lower the price or estimated value of a particular long-term asset that has diminishing value over time. So if you take the smartphone out of your pocket right now, that was worth more when you bought it than it is now. And depreciation accounts for the drop in value. Even though you still have the smartphone, it is worth less than it used to be. And your budget in accounting should account for this. Workstations, hardware of all kinds, and even software declines in value over time, and that depreciation is important to include in your accounting. Net present value is formally defined, as you can see here, as the difference between the present value of all cash inflows and the present value of cash outflows. So the use of net present value is primarily to determine whether or not a project is an acceptable investment. There are formulae that describe the calculation of net present value, but this is the formal definition. And now what you've all been waiting for, and that is a deeper understanding of the principles of managerial accounting. It is not mysterious. Managerial accounting is concerned with providing information to managers, hence the name. And this is in contrast to financial accounting, which is concerned with providing information to stockholders and others looking from the outside. So, managerial accounting includes tools for organizing and directing and for making decisions. So there's differences in the purposes for managerial and financial accounting, and there are also many differences between them that we'll cover in more detail. Managerial accounting, in contrast to financial accounting, focuses on providing data to managers, as I said. So this is focused on the people who are managing some portion of the organization's operations. It places more emphasis on the future than on the present. It places a great deal of emphasis on non-monetary data, so labor, costs, other things. Emphasizes segments of the organization rather than the organization as a whole. So you may have accounting needs for a group within your organization. And the final distinction is that managerial accounting is not governed by what are known as generally accepted accounting principles. You might wonder what this last statement means. Can you do anything you want with managerial accounting? Well, the difference is that financial accounting is used by people or groups that are looking over many organizations and comparing one to the other. So in order to be able to do this, for example, for purposes of planning investments, we should be able to compare one organization with another using similar metrics. So we're comparing apples to apples. And so in order to do this, the field has developed what are referred to as generally accepted accounting principles. This allows an investor to look at three organizations and compare them according to their financials. However, managerial accounting is not intended to serve that role, and so it isn't governed by those generally accepted accounting principles. Here are some of the tools for managerial accounting. There are tools for calculating fixed and variable costs. So fixed costs meaning the cost of a machine. The variable cost may mean the reagents used by the machine that may go up or down in volume. Profit and loss statements, operating leverage, and cost, volume, profit analysis. That last point is simpler than it may seem. It is basically a plot that shows cost, volume, and profit. You can think of the principle that you have to pay for a machine, and once you've paid for it, then any income you receive in using that machine is profit after that payment has been achieved. So a plot of this makes it clear, and this is known as cost, volume, profit analysis. There's a good illustration of this in some of the references that I list at the end of this lecture. There are a variety of budget types, and they differ. I've listed several of them here. A statistical budget, which allows one to analyze various what-if scenarios. A revenue budget, which is pertinent to receipts of a government or a government unit and the expenditure of these receipts. There's cash budget, which is a prediction of future cash receipts and expenditures during a particular time period. An expense budget, which you're probably familiar with. Perhaps you use that to come to this meeting. And then, as I mentioned previously, there are operating and capital budgets. So all these are different. Time value analysis is another topic that would be good to be familiar with in preparing for this exam. So this is basically a means of comparing the future value of a lump sum with the present value of a lump sum. You can see the formal definition of net present value. It is the value of a sum of future cash flows presented in today's dollars. And you can see the formula for NPV below. This is a function on most spreadsheets, and so you may not need to use this formula, but if you looked under the hood in your spreadsheet, this is how it would be calculated. These principles are based on a very simple concept, and if you look at the basics, you'll find that it boils down to the fact that the time value of money is accounted for by the concept of compounding interest. So if you have $1 today in year 0, and if there's an interest rate, let's, for the sake of easy calculation, say it's 5%, then in year 5, that dollar will now be worth $1.28. On the other hand, if you had $1 that you were promised to be paid in year 5, that dollar today would be worth 78 cents. So if someone asks whether you would prefer to receive $1 now or $1 in 5 years, this is the math behind the answer, which is that you prefer to have the dollar now. So this simple concept of compounding interest is behind the more complex concepts such as net present value. Balance sheets. Balance sheets follow the following very basic formula. You have assets, and on the other side you have liabilities and equity. Assets are current assets such as cash or other instruments that can be converted to cash within a year, and you have fixed assets such as buildings and equipment. Your liabilities are current and long-term. So current would be short-term debt, and long-term debt is the other portion of your liabilities. And then equity. And equity is the portion of your assets that you own outright. You can think of this in terms of your own house. You may have a mortgage with debt, but you also have the value of your home, and equity plus liabilities is equal to your asset. An income statement, if you look at the highest level, consists of operating earnings, and the operating earnings are equal to the gross profit minus operating expenses plus depreciation. Now remember that depreciation is the accounting for the declining value of an asset. So your gross profit is not the same as your earnings because you have to account for your expenses and for depreciation. Cash flow is another concept that we refer to quite frequently, and here is the definition. It's the amount of cash that changed hands during an accounting period. So it's the cash that changed hands. So true or false, cash flow is basically the same thing as profit, and the answer is false. So a sale may contribute to profit for the year, but may not result in cash until the next year. So this is what is behind the statement that someone, for example, has cash flow problems. The money is coming, but it's not there now, and yet they need the cash now. That's a cash flow problem. Here's an example of a sample IT budget for FY19. Now, we'll start by the meaning of FY19. That is for fiscal year 19. And traditionally, for your organization, it pertains to the following year. It's usually not a calendar year, although it might be. In our organization, it will run from July 1st, 2018 until June 30th, 2019. In the government, that starts in the fall. So the point is FY19 is for the next fiscal year. In this sample IT budget, which is simplified to show the principles, you have a listing of projects, and then you have columns for capital and operating budgets, and then a sum of the two. So let's start with the data center. The data center is something that has both capital and operating contributions. There's more capital than there is operating in this case, and that means that there's some project or large capital expense pertinent to the data center that year. What might that be? Well, we can see that in that same fiscal year we're planning for an outpatient EMR, and that has a much larger capital budget than it does an operating budget. And so this might account for the rise in the data center capital budget, that we have a big initiative in outpatient EMR. There is an operating component to this, but most of the expense in FY19 is in the capital column. The help desk, on the other hand, is not in the capital budget, but it is in the operating budget. So this is an operating expense that will continue year after year. End user devices, you can see here most of that is in the operating budget, and I would guess that some of that is expansion, but also some of it is depreciation. There is an additional component in the capital budget, and that may have to do with the outpatient EMR. The network budget is mostly operating. So you can see that each of these projects has a capital and an operating budget, and they differ in the balance between the two. But from the point of view of the bottom line, you add up all of the rows and come up with a capital and operating total, and then you add all of those up in that far right column, and that is what is referred to as the bottom line. And you can see total production, total project and production support is summed here. You have 101.5 million capital budget, 64 million operating, and a total of 165.5 capital and operating budget for FY19. The costs of HICT, which stands for Health Information and Communications Technology, can be divided into three buckets. Implementation includes support, training, building, administration. Maintenance, which includes support and maintenance contracts, application support, user support, technical support upgrades, complying with the prodigious number of legal and regulatory requirements. And then a third category, which is for research, development, training, and evaluation. The balance between these may vary in your organization. The reason for this listing is to make sure that there is a broad understanding of all the costs that aren't necessarily thought of when you say you're going to put in a new EHR. You think about the implementation, but we should also be thinking about maintenance and for RDTE for that project. And here is another quiz. The largest category of hospital expenses for most organizations is A, pharmaceuticals, B, depreciation, C, salaries and benefits, D, provision for uncollectible accounts. All of these are categories, legitimate categories of expenses for a hospital. The largest by far is salaries and benefits. I suppose there are organizations somewhere where this is not the case, but healthcare is a very labor-intensive field, and those laborers, which are of course professionals, in many cases have salaries and benefits that may account for about 50% of the budget. And here is a pie chart of the hospital expenses for a fictitious organization, but the principles are likely similar for your own organization. And you can see here the point that we made in the quiz, that salaries, benefits, and wages account for about half of the expenses for this hospital. Pharmaceuticals about 8%, other supplies 31%, depreciation and interest, which we've discussed previously, 8%, and then 3% for uncollectible accounts. So understanding this distribution helps you understand where return on investment may be greatest for investments in health information technology. Certainly, reducing expenses in any category would be helpful, but the biggest return is likely to be those investments that address the biggest part of expenses, which are salaries, wages, and benefits. Now, this is an old slide, but a good one. I think principles still stand, that when we're calculating return on investment from clinical systems, there's likely to be a distribution that looks something like this. This is from Partners in 2002. John Glasser gave me permission to use this slide. By the way, ROI here stands for return on investment, not release of information. So you can see the categories of return for clinical systems, including savings of 29% in drug savings. And remember from the previous slide, our fictitious organization had an 8% expenses accountable to drugs. And then you have adverse drug event prevention. Adverse drug events are harmful, but they're also expensive. Transcription savings, chart pull savings, decreasing building errors. Most organizations do achieve a return that accounts for greater financial efficiency in the billing transactions and accuracy of bills, radiology savings, lab savings, and so on. So if you were to analyze your own organization, you might include some of these categories in your ROI calculation, and you may have others also. The concept of total cost of ownership is important, and its components are shown here. The idea behind total cost of ownership is that the purchase price or licensing price of an asset is only a portion of its total cost. So you can think of the cost for a computer, for example. You may have a price to purchase it, but operating that computer, including infrastructure, electricity, security provisions, and also the future expenses for replacing that hardware, upgrading it, decommissioning it, all should be included in the total cost of ownership. So this is a useful concept when planning investments, because it may be that operations for an inexpensive component may be greater than the cost of the component itself. In fact, in many cases they are. And so your total cost should focus on operations. The point here is that you consider the life cycle of a system or a project, not just the initial purchase or licensing cost. And we'll come back to that when we talk about implementing clinical computing systems. So here are some additional suggested readings. Again, the idea behind this course is that you are reviewing things that hopefully you have some understanding of before taking this course. And if you find that you are a little weak on some of these concepts, it would be very useful for you to recognize that and to pursue these readings and maybe some others. I list a book here published a few years ago on the electronic record as evidence. There is a chapter by Jackie Zahner and Sally Behan on legal issues in health information management. And then it's very useful to read the Hipaa security rule at hhs.gov. There's a book by Kapinski on financial concepts in healthcare. That would be a good place to start if your background in the finance is a little weaker. I would encourage you to recognize the areas that you aren't as comfortable in and to bolster your background in that before taking the exam. And that concludes this lecture.